Depressive disorders and bipolar disorders review for the PMHMP ANCC exam, Part 1. Sadness is a common normal human emotion. PMHMPs caring for clients who present for evaluation of depression must distinguish between normal levels of sadness and pathological levels that are symptomatic of an underlying brain-based illness called major depression. Major depression requires treatment and generally will not fully abate without therapeutic intervention. Untreated major depression predisposes people to other serious health problems, so pathological levels of depression should not go untreated. Sadness continued. Sadness is one of the most common human emotions, and it exists on a continuum ranging from the absence of depression at one end and to the pathological levels that produce significant symptoms of a psychiatric disorder called major depression at the other end. Cultural differences affect behavioral manifestations of depression. Mild depression can be a healthy reaction to life stressors that motivates a person to deal with life events and emotions. Sadness can be pathological if it is disproportionate to events and sustained over a significant period of time. It significantly impairs normal social functioning, such as occupational, social, relational functioning. It can also be pathological if it significantly impairs normal somatic functioning, such as appetite, sleep, self-care activities, sexual functioning. And it also may be apparently unrelated to any identifiable event or situation in a person's life. Major depressive disorder, MDD, is one of the most common psychiatric disorders, the primary unipolar affective disorder. It's a complex, brain-based illness with a primary characteristic of persistent disturbance in mood, an excessive or distorted degree of sadness that manifests with behavioral, affective, cognitive, and somatic symptoms. Major depressive disorder may have known precipitating events or situations, but often occurs without any precipitating stressors that can be identified. Major depressive disorder significantly interferes with daily functioning and goal attainment, and it has complex genetic, biochemical, and environmental etiological factors. The etiology of major depressive disorder. There's multiple theories of the etiology of depression, and they fall into two categories: psychological etiologies and neurobiological etiology. Psychodynamic theories of depression: object loss theory, aggression turned inward, cognitive theory, and learned helplessness is what is discussed. Object loss theory assumes that early psychological developmental issues lay the foundation for depressive responses in later life, that the accomplishment of the first stage of development in which the child is able to form a relationship is normal, and that during the second stage of development the child experiences traumatic separation from significant objects of attachment, usually a maternal object. Loss may be related to maternal death, illness, or emotional lack of availability, and is unexpected and overwhelming. The depth of loss produces constellation of responses dominated by separation anxiety, grief, mourning, and despair. This critical object loss event predisposes the child to respond in similar ways to any future losses or significant separation. Aggression turned inward theory by Sigmund Freud. This theory is very similar to the psychodynamic theory of object loss theory just discussed. It assumes the same thing, that early psychological developmental issues lay the foundation for depressive responses later in life, that the first developmental stage of relationships are normal, and that during the second stage of development the child experiences the loss of the significant mothering person. The loss can be real or imagined and is unexpected and overwhelming. So that differentiates from the object loss theory, that the loss can be real or imagined and is unexpected and overwhelming. And this is aggression turned inward. The loss may be related to a maternal death, illness, or emotional lack of availability, or to the birth of a new sibling and the child's perception of losing undivided, individualized attention from the mother. The child's initial reaction is anger. However, the child feels unsafe to express this anger openly and directly. This may relate to the child's fearing further loss if he or she responds with anger, or his or her subjective perception that anger is unacceptable. The child uses defense mechanisms to deal with conflict created by the desire for the love object, but co-occurring with anger for the love object. Instead of anger being expressed outward at the maternal figure, it turns inward because it is more acceptable and safer to be angry at oneself than at the mother. Anger at oneself is rationalized as the child assumes that loss of the mother was related to something bad that he or she did rather than to the caregiver's actions. Excessive guilt becomes a manifestation of the process of dealing with aggression experienced with loss of the mother's attention. A similar emotional reaction, such as low self-esteem, excessive guilt, inability to cope with anger, self-destructive impulses, occurs as an adult whenever a loss is experienced. Cognitive theory of major depression. This theory represents a cognitive diathesis stress model in which developmental experiences sensitize a person to respond to stressful life events in a depressed manner. Cognitive theory assumes that people with a tendency to be depressed think about the world differently than non-depressed people, and that depressed people are more negative and believe that bad things are going to happen to them because of their own personal shortcomings and inadequacies. This thinking promotes low self-esteem and beliefs that the person deserves to have bad things happen to them, and promotes pessimistic perceptions about the world at large and about his or her own future, as well as it globalizes the negativity to all events, or they globalize negativity to all events, situations, and people in their life. When confronted by stressful events, these people tend to appraise them and the potential consequences in a negative, hopeless manner, and therefore are more depressed than people with different cognitive styles. Learned helplessness or hopelessness theory is Martin Seligman. This theory is a modified aspect of cognitive theory which assumes that a person becomes depressed due to the perceptions of lack of control over life events and experiences. These perceptions are learned over time, especially as a person perceives others seeing him or her as inadequate. Perceptions of lack of control lead the person to not adapt or cope effectively. The person's behavior becomes passive and non-reactive because of self-perceptions of personal characteristics of being helpless, hopeless, and powerless. Biological theories on depression etiology. Genetic predisposition. This is a clear genetic predisposition to depressive disorders. One assumption is a polygenic single nucleotide polymorphism (SNP) disorder. Having a depressed parent is the single strongest predictor of depression. Children of depressed parents are 3 times more likely to experience major depressive disorder in their lifetimes than the general population and have 40% chance of having a depressed episode before age 18. The earlier the age of onset for major depressive disorder and the more severe the symptoms, the more likely it is that a person has a strong genetic predisposition for depression. Endocrine dysfunction. Major depressive disorder has symptoms that suggest endocrine abnormalities as part of the etiologic picture. Neurovegetative symptoms commonly seen in major depressive disorders such as sleep disturbances, appetite disturbances, libido, lethargy, and anhedonia are related to functions of the hypothalamus and the pituitary and the hormones they secrete. A high incidence of postpartum mood disturbances is suggestive of endocrine dysfunction. Dysphoria is often triggered by changes in levels of sex steroids that occur during the menstrual cycle. Deregulation of the hypothalamic pituitary adrenal axis, or HPA axis, which controls the physiological response to stress and consists of interconnected feedback pathways between the hypothalamus, pituitary gland, and adrenal glands. In another theory of an endocrine basis for major depressive disorder. In this theory, major depressive disorder is presumed to be, at least in part, a result of an abnormal stress response related to the HPA dysregulation. In response to stress, the hypothalamus releases corticotropin-releasing hormone, or CRH, which then stimulates the pituitary to release adrenocorticotropic hormone, ACTH. This then stimulates the adrenals to release cortisol. Hyperactivity of the HPA has been shown to be present in people with major depressive disorders, as have possible elevated cortisol levels. Over time, elevated cortisol levels damage the central nervous system by altering neurotransmission and electrical signal conduction. Evidence supports that cortisol over time can cause changes in size and function of brain tissue. Evidence supports that major depression may be associated with pro-inflammatory cytokine activation. HPA dysregulation is the rationale and scientific basis for the dexamethasone suppression test, or DST, a screening test for depression, which has proved to be too nonspecific and is not commonly used in clinical practice. Abnormalities of neurotransmitter function. All of the following are possible neurotransmitter function abnormalities that cause depression. Dysregulation of one or more biogenic amine neurotransmitters such as dopamine, serotonin, or norepinephrine. Low levels of endogenous catecholamines in specific areas of the brain. And serotonin levels were shown to be low in post-mortem studies of people who commit suicide and in people with major depressive disorder. Low level of precursor tryptophan. Low levels of serotonin metabolite, the 5-HT-IAA, and receptor sensitivity for neurotransmitters set unusually high in specific areas of the brain. A stronger neurotransmitter receptor cascade is required to induce neuronal activity. Low density of receptor sites in specific areas of the brain. Hypometabolism in specific areas of the brain regulating mood, appetite, and cognition. And complexity of brain functions implies that the etiology of complex disorders such as major depressive disorder involves the relative balance of available neurotransmitters and not just a low level of one neurotransmitter. Structural brain changes. Neuroimaging has shown consistent abnormalities in certain structures of the brain in people with chronic and severe depression. Hypovolemic hippocampus, hypovolemic prefrontal cortex limbic striatal regions, and major depressive disorder is a common comorbidity in people who have experienced brain damage, including damage from stroke and trauma. Chronobiological theory. Desynchronization of circadian rhythms produces the symptom constellation collectively called major depressive disorder. Circadian rhythms control biological processes that are frequent problems in depressed persons, such as interrupt sleep-rest cycle, REM abnormalities, frequent wakening, intensified dreaming, diurnal variations of circadian-related behaviors, decreased arousal and energy levels, decreased activity patterns, increased cortisol secretion, and increased emotional reactivity. This concludes the end of Part 1 of the Depressive Disorders and Bipolar Disorder chapter recap. The Part 2 will start with incidence and demographics, risk factors, prevention, findings, medications, and follow-up.